And so building on a lot of the work that had been done across the San Francisco Department of Public Health primary care network for the past 5 years that had really focused on leadership training, primary care quality improvement, data structure, empanelment of all the patients. At this point, our assessment reflected that and showed that team-based care was really the next step, and building that infrastructure would really be the platform to then work on improving access and improving care coordination. So that's where we started.
Going forward.
So I think one thing that's really interesting in reflecting back in terms of things that we had done a lot of work on is we had done a lot of work on more traditional quality improvement work. And I think the move to medical home and team-based care has really been a culture shift for us because we had some early steps in this. So we started doing provider panel reports and doing some specific carve-outs to do some panel management and training our staff a little bit to look at our registry data and doing outreach calls. We managed to boost some of our traditional quality improvement metrics by doing that, improved our PAP rates and our mammogram rates and some of our diabetes rates. But we really needed a fundamental shift in how we did business. And that has, because we really figured that we were kind of hitting the ceiling on where we were able to go with just a little bit of outreach calls here and a little bit of putting some run charts on the wall. So we really had to take a step back and say we're going to pull back from that and just really kind of fundamentally restructure how we offer care. And the biggest culture change, I think, for us has been that we really have been a system, much more sort of traditional primary care system where the responsibility for the patient really rests solely on the primary care provider, to thinking of it as a system in which the whole team is involved and that responsibility is shared. And really when we looked at where things were falling between the cracks in clinic, it often was because the primary care provider just running on the hamster wheel just couldn't keep up with those things. But of course it can be actually a real game changer and sometimes even stressful to start talking to other staff members about sharing the care and sharing the responsibility for the patient. So we've put a lot of work into working with our staff around that culture shift.
So I think it's really easy to say that Teams is our biggest weakness, and all over the country, that's what primary care practices are struggling with, trying to make teams, and they have maybe 4 providers and 8 staff, and they're trying to make teams, and there's a lot of difficulty around that. And when people have asked me about academic medical centers and teams, again, just like that conversation with Rena at the beginning of last year, I say, you know, it's basically impossible because you have so many part-time providers, and they're set in their ways or the staff are set in their ways, and how can you even begin to conceptualize a team when you have 83 part-time providers? So that's the GMC is about 83 part-time providers. So how did you overcome that specific barrier to actually conceptualize and start making teams?
Great. So absolutely, probably the biggest hurdle and one of the steps that we spent the most amount of time on was how do we construct teams that really are truly multidisciplinary and retain the integrity of the goal of team-based care for primary care practices where most people are closer to full-time and staff are full-time and they're really working together Monday through Friday, the same provider, the same medical assistant, the same nurse. How do we try to replicate that model in a clinic where every half day there's different providers there, and even the staff, many of them are part-time. So we took a 4-step process. And we wanted to kind of walk through each of those steps as we change things within our own clinic. And the first one was really focusing on creating a team structure by reviewing all of our FTE of staffing and the schedules to figure out how can we create stable teams and stable teamlets so that the same people are working consistently together. It may not be Monday, Tuesday, every day of the week, but at least it can be every Monday afternoon, the same resident with the same medical assistant. And so the next slide shows our getting into kind of the nitty-gritty of our staffing ratios, what our teams are constructed to be. And we started this process looking at our own staffing ratios, looking at staffing ratios in high-functioning medical homes across the country, and had an ideal vision of what the ratios would be, where there would be one nurse with one clerk, with one provider, et cetera. And yet realizing that to do this, we had to move forward with the staff that we had and the ratios that we had. And so we developed 3 care teams, dividing the full population of the general medicine clinic into 3 teams, each of 2,200 patients. And each team has 2 teamlets of 1,100 patients. The bigger team, there's 1 FTE of a registered nurse, 1 FTE of a continuity nurse practitioner who really is critical, plays a critical role in the glue of continuity for patients who come in on days when their own primary care provider is not in clinic, an outreach panel manager who's a medical assistant or health worker, and a behavioral health clinician. We formed integrated behavioral health in this process as well. And then those staff are paired with 2 teamlets that are composed of the number of providers that care for 1,100 patients, which in our clinic means that for each teamlet, whereas in a community health center this would be 1 provider, for us that means 4 to 5 attendings and about 8 to 9 residents who all work as much as allows with the schedule with 1 consistent medical assistant, so that medical assistant is working with those 4 to 5 attendings with on a 1-to-1 ratio when they're in clinic, and 1 medical assistant to 2 residents when they're in clinic, but as much as possible the same people working together consistently, and 1 clerk.
So to kind of add to that, I think I was just thinking as Rena was talking that we had several aha moments during the journey as we had meeting after meeting after meeting after meeting after meeting with our staff to try and think this through. And one of them was when we were thinking about, okay, we have 82 providers, so we're going to have 4 teams with 20 providers each, or how can we do this? And all of a sudden we thought, of course, a provider does not equal a provider in an academic clinic. Our interns, for instance, carry like 40 to 50 patients, whereas an attending might carry 100 to 200 patients. So one of our aha moments is thinking, we have to define the team by the number of patients. We take the number of patients, and then that drives how many providers you actually put on that team. So that was a really critical thing. And then I think that we were also looking at some other clinics that. Another thing was just looking at the staffing ratio. So Rena really became the expert of staffing ratios of all the different places we were looking at. And although we could have told you a year ago how many staff we had, we couldn't have told you how many provider to RN to MEA to clerical staff we had in terms of creating a team. And it was really, really important to actually just put down on paper exactly what we had and look at how we compared to other high-performing medical homes. For our staff, that was actually very gratifying because our staff really wanted to know some of the details about how we were going to pull this off. So there were some key staff meetings where we actually came and we said, look, this is the number of providers we have. Here is how the team might work, and that was really kind of an eye-opener for staff. We also, it was really helpful to see a couple of different best practices, both best practices in medical home models where they had been able to upstaff to a more idealized model, like our colleagues here at the VA in San Francisco, but also like our colleagues down in San Mateo Medical Center who actually were able to move to team-based care with the existing staff that they had. And that also represented both an academic clinic and a safety net clinic, so that we wouldn't allow ourselves to use either of those factors to stop us in our quest for medical home. But of course, at the heart of everything that we did really was the idea of having the patient have more than just their PCP, but they considered a key part of their health team, because we really think relationships is at the center of all of this. So we really want our patients to be able to come to clinic and feel like they not only know their provider, but there's also, there's that nurse that I saw the last time I was in here, and here's the MEA who called me on the phone and who always takes my blood pressure when I come in. So we try to keep the patient at the heart of everything. So this next slide is we thought it might be interesting to show everybody just what our teams look like. And this is probably not going to blow anyone's mind who actually currently works at an academic clinic, but when we show this to we have a really great group of colleagues in the San Francisco safety net in the both the DPH clinics and the community health centers in San Francisco, but they're much smaller clinics than we are, and they're much, much smaller in terms of their provider staff. So we like to show them this slide because it kind of blows their mind in terms of exactly what David's been asking us about is just the number of providers that we are trying to work with. But this is how we actually divided it up, and it actually, again, was just really nice to get things up on, on paper and front and center for people. So you can really kind of see how we divided it up and how which staff members are associated with which teams, and just the immense number of providers that are on the teams themselves.
And the astute observer will notice that Team Yellow, it happens to be the best team.
No.
This is sort of a chance because we don't have a chance to see our audience when we do these webinars, so I can just be like, this is really awesome, everything that has happened so far in terms of setting out to make teams in such in this type of environment, and it's really inspirational. And so my next question is, so then what?
One thing that I wanted to add to that too is that just in terms of process, I think the nitty-gritty of the process is exactly it's one thing to kind of put up nice slides and talk about the idea of team-based care, but it's really like the nitty-gritty of how you actually do these things. One of the things that was really interesting to us, we had an immense number of staff meetings around these changes, and we really learned that our staff really, really values transparency and involvement. And again, there's so many players in our clinic that can be really hard, but we kind of adopted the philosophy that we can't pay people extra for getting involved in this work, but we can always buy them lunch, so lots and lots of lunch meetings. When it came time to choosing who was on what team, we talked to a lot of different clinics about how they had done it. In some cases, they had the nurse manager and the medical director go off in a room with a whole lot of stickies and lock themselves in until they came up with teams that sort of matched personalities and pre-existing work relationships. In others, they had a completely transparent process, and that's what our staff wanted. So when it came down to it, we did have to create teams partly with balancing some part-time staff with other part-time staff and schedules, partly with balancing language. But after we got past those certain people that we had to assign in a certain way, we actually very publicly and with the staff involvement just drew names for the teams out of, I think it was an emesis basin, actually not a clean emesis basin. In clinic, we invited all the staff to come, and they were allowed to draw names, and that's how we were completely above board and transparent about how we did it. The next thing, though, that we really had to do was define the roles, and that has been really critical and took a lot of work together because we actually had to sit down and we had to start writing down all the functions that the different staff members in our clinic currently perform, and all the functions that needed to be performed in a medical home if there were additional functions, and really tried to look, and actually it was totally eye-opening for almost everyone, because in almost all cases, staff members had additional responsibilities on their plates that the other staff members and we, even in leadership, sometimes knew nothing about. But it was very helpful to just write it all down in terms of who did what in clinic. And I think this is something that is continually evolving. We continue to work on our team model, and especially as we try and progress along sort of a share the care model where staff members take some of the responsibility and communication with the patient. They share that with the primary care provider. This is a continually evolving thing. We're about to launch electronic health records too, so we're going to have to go even further into what role everybody plays. But again, we are very above board, transparent, and as we've been able to get these things down on paper, we've been able to have small pilots of adding additional roles to some of the staff, always with the knowledge that we need to take something off their plate when we put something new on, but that we really I think our staff was actually great about helping us think through what does the patient need, and then how do we define everybody's roles based on what the patient actually needs when they come into clinic.
I would add to that I think that what has been really exciting, one of the driving forces to really move forward our transformation in clinic is that very early on in the process, we with each staff group, spoke to them and identified champions, medical assistant champions, clerical champions, nursing champions who participate in our medical home working group. And this kind of detailed process of going through what roles every person on the team plays, we did collectively together with representatives from every group and really mapped out, these are all the tasks to be done in clinic and who is the right person for the right work to create these roles. And people have found it valuable to have it clearly laid out, as this slide is somewhat schematic, but we have a similar, more detailed description so that everybody on the team knows who's responsible for what. And that's really been key to the shifting process.
We should also add that actually working with our nurse manager has been totally critical to the process, because we're in sort of the strange position that I'm sure many people are in different academic clinics, where we, UCSF actually is the employer of all of our faculty, but the Department of Public Health is actually the employer of all of our staff. So it's very interesting, because there's been, I think for us in medical leadership, there's been a lot of coordination, indirect leadership, vision setting, but we actually aren't in a supervisory relationship directly with any of our staff. So it's been really, really critical to have the support and buy-in of the actual Department of Public Health leadership in our clinic.
So after going through the process of really looking at team roles and functions and mapping out workflows, the next step was really building the infrastructure for communication. And as everybody knows, the communication and relationships are the key to teams. Again, all the more important in a clinic where most of the providers and as well as the staff are part-time and not there consistently. And so one of the key ways in which we have put together time to allow people to meet face-to-face together and focus a lot of our energy on is developing our team huddles. And this required a shift in our templates that our residents use. This is a picture of a huddle with one of our residents with their team nurse, team medical assistant, behavioral health specialist, and clerk, reviewing, and for every session of the day, we blocked out time so that the teams can review the patients who are scheduled for that day and identify care needs. And this is really a process too, and continues to be one of really making these huddles and the communication as useful as it can be. Previously, the way that our teams and our staff often function in clinic was they would be working simultaneously but almost never talking together, and just the having a time when everybody is in the same room together, knowing each other by name, has gone a huge difference. One of the things our medical assistants used to say that they wished the most for working with residents and attendings was that their providers would know what the name is, and I think that's definitely something that far we have accomplished. And then it's also been a process of coaching in terms of equalizing the playing field for every member of the team to really feel like they're contributing at the huddle to their role specific to the patients who are coming in that day. So really encouraging our clerical staff to share the results from the confirmation calls that they do prior to the visits for patients. The medical assistants, and we'll talk more about this as we go on, the medical assistants share their chart prep that they do in pre-visit planning, and the residents share what anticipated care needs they have for their patients from their pre-rounding.
And I should also add, before we talk about the team dance, that all of our changes are still very much a work in progress too. So I think one of our, on our best days, our huddles are great, and they're a great communication tool, and people are really critical information is getting passed back and forth. But I think we've also had some of the struggles that every clinic that tries to implement huddles has had, with some days are not such good huddle days, and team members may show up late, or it'd be a little bit unclear about how to move the huddle along efficiently. And so those are very much things that we're working on, and we're always encouraged when we talk to other clinics who say, yeah, it took us a few months to really get those huddles till they were strong. So we keep working on that. The other thing that we've implemented, the other big thing I just wanted to say that you see the little Coleman Associates logo down in the bottom, and this is an example of our team dance. We got a big boost actually in our change work when Our managed Medicaid plan in San Francisco, the San Francisco Health Plan, offered to sponsor several safety net clinics to go through the process of Coleman Associates consulting, and that was very, very intense, but very, very helpful because it gave us a number of concrete recommendations that we could implement during the actual workday that could really enhance communication and improve patient flow through clinic. So this year is the team dance, and that's actually a term that came from Coleman, but it really has been something we've tried to implement in the ongoing workflow of how a clinic day runs. And a really key element is really, really close communication between the provider, you can see on the left, and the MEA, medical assistant, who you can see on the right. And that includes things like frequent check-ins during clinic, a midway knock where the medical assistant knocks on the door in the middle of the patient visit to see if the provider needs anything, and in some cases to kind of nudge the provider to move a little bit more quickly. Over communication, and really trying to start and end the clinic on time, because we've traditionally been a clinic that we do a lot of great work, but we're always getting started a little late, and then we're going to the lunch hour, and we're going until 7 p.m., and we really wanted to focus also on efficiency and getting patients seen efficiently and people to actually have clinic sessions that fit within the time that they were supposed to. The other thing that we did that we were really excited about, and something that we felt like we needed to do for a long time, is we launched an integrated behavioral health team in the clinics. And I think anybody who works with a patient population that has a lot of psychiatric or substance use or comorbidities or struggles with housing and food security issues knows the importance of this and just the burden of these issues in a typical primary care clinic. So we were very lucky to be able to take advantage of a movement to move in this direction in San Francisco, and every team actually has a behaviorist that can take warm handoffs from the team that day to do some brief counseling or some other kind of intervention.
Great. So then the fourth step to our team development was really actively coaching team members to adopt their new roles in clinic, as well as having team retreats where we brought everybody together to focus on teamwork. And then the other component of that is trying to be really data transparent and have moved to having real-time, week-by-week data dashboards by team so that the team really can get feedback on their performance in real time. So here's a picture of one of the metrics that we started tracking when we rolled out our teams in June. One of the key roles of the medical assistants on the team is doing pre-visit planning by prepping charts to identify care needs, and really went from 0 to nearly 90%, and they've really retained that improvement across time.
And I'll just briefly say that another key element that we've added for our clerical staff is doing confirmation calls for all patients, and now we're calling most patients before their visits in, so our no-show rate, which has historically been impossible to budge at 30%, has come down closer to 20%, and now we're all sort of experiencing the shock of having full panels, but we have a lot more communication with our patients.
So now we'll turn the tables, and I get to be Katie Couric and ask you, Dave, some questions. So as a resident in clinic who started out in clinic as an intern a year before we launched our team-based care system, and now having a number of months as part of the teams, what has this change meant for you, and what does your clinic day look like now?
Yeah, so thank you. I mean, first of all, being an intern, period, is kind of has its own shock value. And so it's been really interesting to start residency and start clinic at the same time that this whole process is starting. So just to sort of walk through what it's like for me, I show up to clinic at like 12:45, and from 12:45 to 1:15 we have our pre-clinic conference where we hang out in the provider room and topic of the day. And then from there each of the provider goes to their separate team meeting with all the staff from that team. So I go to my yellow team meeting, and the yellow team nurse is there who leads the meeting and introduces everybody, asks if anybody has any special needs for the day. So the behavioral health integrated person is there, and they say, you know, if they have time to see people in the day, and we say which of our panel, you know, which of our patients for the day is special needs maybe and needs to see the nurse or the behavioral health consultant. And then I go and start seeing patients after meeting with my medical assistant and running through the list for the day. And throughout the clinic, where I'll see, at this point in my extensive training, we'll see my 6 patients for the half day. I'm really just working back and forth with my medical assistant, and then occasionally walking over and speaking with the nurse if there's someone who needs a little extra attention. And then I'll go down to Carrie and Lindsay's office, who are the behavioral health folks, and say, hey, I have this person who has admitted to me during the session that they're feeling suicidal or what have you. And so it's this really dynamic experience of the clinic, and it's been so much fun and so fulfilling. And this has been the evolution for me. I mean, this is kind of describing what my last 3 or 4 clinic sessions have felt like.
So tell us more about, as this is a work in progress and an evolution, how have these changes felt and affected your experience in clinic, both the things that have improved and some of the challenges?
And you can be really honest.
Yeah. Well, so there's so many immeasurables that we can't, in other words, there's no percentage of how it feels to be supported in a residency clinic, because as a resident, you'll hear over and over again how difficult it is to drop everything you're doing in the ICU or on the wards and then come to this clinic where in the past it's been kind of an island. You know, you're on your own, going from this large team of the ICU where everybody's going back and forth and there's so much banter, to just seeing your patients who you feel so helpless to take care of. So now I feel so supported. I really know and trust the people I work with. And the culture of teams and just optimism in a way that everybody feels like they're contributing to the care of our patients. I mean, it's really, I don't mean to hyperbolize anything. It's really how it feels for me. And it's been phenomenal. And sharing experiences with residents who are at other sites, you really feel fortunate to be a part of this process. So I'm, a pessimistic guy, obviously, but this has been really awesome. And so for you guys, how has the experience been for you? I mean, I speak about this in such it's been so good for me. How has it felt? How has, with all of your experience, how has it been for you? What are the challenges that we still have to overcome?
I think it's felt great to get where we are, but there's definitely a lot of challenges. And I think one of the challenges we just keep alluding to is that communication is so challenging in a clinic with so many part-time providers, but also staff that we sometimes share our hospital, sometimes we have to share our staff with medical specialties or with another unit, and so that can actually be challenging just to keep everybody on the same page at the same time. With 83 providers, we literally never have a provider meeting where all the providers sit down at one time, and that kind of, again, blows everybody's minds and our community partners when we talk to them about that. So we've had to try really hard at clear communication, including a lot of email communication and just repeating things. I always say in GMC, once you've said everything to everybody once, it's time to go back to the beginning and either say it all again because they forgot or say the next thing. So we're continually communicating all the time. Working in our budget is an integral part of the city's budget, and so we are always subject to budget freezes and staffing freezes and sort of the challenges of some of a large city HR system, and that can be really frustrating and hard when we know our model is going to work if we actually have all the bodies and the positions, but we're in a hiring freeze and we've got a third of our clerical staff that we can't fill those positions. That's immensely challenging, and that's hard to keep explaining to people all the time, the barriers that we work with. I do think that we've learned a lot also in just working with our own staff about how different staff members react to change, and we have had some staff that have really jumped on board and just been phenomenal and really been early adopters, and then other staff that have kind of come along more slowly. Some of those staff have become some of the biggest champions for the team model, and even some of the early adopters can get frustrated that the pace of change is not fast enough. So we're always having some conversation with someone who either feels like we're not changing fast enough, and then turning right around and having a conversation with someone in clinic who feels like we should be changing faster. So those are really our challenges. And we really do want things to work for our patients as well and all of our providers, but really also for our residents. And so I know our third years in particular have been dealing with a lot of change this year, and we're hoping that things will kind of settle out into like this is just life is normal, and now we have team-based care in a way that does feel really supportive for the majority of our residents.
Okay, your turn to be Katie Couric, audience, our patient audience out there.
Excellent. Well, first of all, thanks so much to our great speakers. Incredibly informative and inspiring work that you're doing. So let's kick off the questions. Let's engage the audience a little bit. We've had a bunch of great questions already come in, so we'll start off with one of those. If you do have a question, please either send it through the question field on your webinar panel or click to raise your hand, and we're going to call on you and unmute you to ask your question. For those of you who are still on the phones, hold tight. We'll be opening up the phones in about 10 minutes to unleash your questions as well. But let's get started with Erica Pabo, who submitted a question about the relationship between medical assistants and patients, and that as an issue for transforming practices. Erica, can you ask your question and introduce yourself?
Yeah, sure. Thanks, Andrew. So I'm Erica Pabo. I'm a half-time resident at the Brigham and work half-time at the Center for Primary Care at Harvard, working on our Academic Innovation Collaborative. So really excited to hear about what you guys are doing at UCSF. In our work with our Innovations Collaborative, our clinics are all working on team-based care, and many of them have settled on similar approaches to what you guys are doing, given that they're very similar clinics, lots of residents, lots of part-time faculty. So they're also trying to use MAs as the continuity, or in some cases, LPNs. But many of them are struggling with how to modify the way in which the MA interacts with patients, with the team, so that the patients really identify the MA as continuity. And was curious to hear, sort of in your early experience, how that's working for you guys and how you've changed the MA's role to make that work. Thanks.
Yeah, thank you so much, Erica. So I think I can just respond to what I feel has been the biggest change in that regards, and I think that the consistency of the same MA working with the same provider and thus the same panel of people that we're caring for is the biggest step to that. And I try and, as a provider, and I think other providers are doing this as well, really Claire mentioned that sort of that mid-visit knock, and so when that happens, I try and really address. I say, hey, Jamie, come in. This is Mr. Smith. We're caring for this person together, and so I'm only able to do that because I always work with Jamie, and Jamie has such an amazing personality that over the course of the year and a half. Or the 6 months since this all began, the people that are on my panel start to get to know Jamie, and so I think that is probably the biggest step to that. But there are difficulties because, like everybody else in kind of the, people are on leave and some of the staff absences that Claire mentioned, just because for whatever reason, so that always becomes difficult. But I think consistency of teams, as soon as you set those teams and you stick to them, that's the first step.
we also had an interesting experience where we've been trying to design a new team brochure to hand out to our patients. And we were just going to design a brochure that kind of described what a team was, but put a bunch of pictures of different staff members on it. And then we realized that, hey, if we actually hand this to a patient and they are actually on Team Orange, for example, but it's got a bunch of people from the other teams on it, it might be kind of confusing. So we're trying to now create things where some of the key members of the team that are around more often are actually pictured in the patient handout, so that they kind of start getting used to the idea that, like, here is your team and here's the faces of your team, because especially in a clinic with a lot of low literacy issues, the picture is worth probably several thousand words.
Excellent, great question. Let's now go to Pratish Gandhi. Pratish has a question about chronic disease management in a residency setting. Pratish, we're unmuting you. Can you introduce yourself and pose your question?
Sure. So it's very nice to be on the call, and thank you all for that very nice conversation. My name is Pratish Gandhi. I'm a second-year Med Peds resident at Tulane, and we're very much in the middle of this process now, trying to redefine our Med Peds continuity clinic. Some of our challenges are obviously financial. We work in a very conservative state, and money is extremely hard to come by. So, listening out on the onset, I worry about, or I have questions about the adaptability to a clinic setting where we have 1 or 2 MAs per 60 patients, or 1 nurse per 6 or 7 residents. How can we alter the team-based model, or how can we alter the model to apply to our setting? I guess that's sort of my first question. And the second question is, how has the team-based model affected the outcomes, at least in the short run, of chronic diseases for your patients? And I ask this in the setting of, for example, thinking about Dr. Fernando Pugli's healthcare model in Cambridge, where he employs health coaches. In his private setting, he's able to do so. They basically take chronic health management out of the clinic and beyond the 4 walls. From what I'm hearing, it sounds like your MAs are empowered and get to a point where they're able to almost act as health coaches, if you will. So I'm curious to know, how has the chronic disease management gone during the team-based setting, and then how do you adapt this model to even a more resource-poor setting like ours in New Orleans?
That's a fantastic question, and one I think that gets at the crux of why this work is challenging, and especially all the more challenging in resource-constrained settings. And when we were talking a bit about how we really started this process by spending a lot of time focusing on the structure of the teams and our staffing ratios, even though we could imagine the idealized staffing ratios where there was 1 nurse for every provider and 1 medical assistant or more for every provider, the reality was making this happen with what we have. We are fortunate that we are, though in a county setting and work in the Department of Public Health, we are in a city and county that is fairly progressive in terms of funding. That said, it's the same challenges of expanding roles within the context of what a person has the time to be able to do in that clinical session. And so many of our medical assistants have undergone health coach training. That said, in practice, it's challenging for them to have the time with the patients in the space to actually do that health coaching. And so we are exploring other models, and a number of our community partners, as well as the Family Health Center Clinic, which is also a resident clinic on campus here, has explored different models of employing peer health coaches and health coaches to be a part of that care team and continuity. That specifically is not something we have done. Another role I'll talk about is the role our nurses play in chronic disease management, and that has really been for a number of years now a way that we've expanded chronic disease management to the team, and that a number of our patients are scheduled for chronic disease visits with the nurse for follow-up, as opposed to back with their primary care provider, and that nurse will review their insulin regimen, their blood sugars, can titrate meds based on standing orders, same for hypertension, do patient education and motivational interviewing, and so stretching stretching the staff that we've got to expand as many roles as possible, but while being feasible or being conscious of what's feasible for a person to do with the ratios that we have.
And I think it's interesting because we are a pretty generous city for healthcare, but our staffing ratios are not that rich, and especially if you look at our staffing shortages, we are really not one of the more robust clinics in terms of, so it actually would be interesting to see how our staffing ratio compares to your staffing ratio. I mean, one thing that's been really interesting is we have had a great development over the last few years is that our Healthy San Francisco program managed by the San Francisco Health Plan has developed a bit of a pay-for-performance program where clinics get to have a little bit of a discretionary fund. We've been able to use that fund to bring some stipended volunteers into clinics who actually have done a lot of our outreach work and our panel management and are able to run reports off of our registry by which we can do panel management. We've actually had to kind of create that as a parallel structure to our staffing structure because we, as part of this large DPH system, have not been able to say, you know, hey, let's just go create 3 more health coach positions and we know that we can kind of realize the gains from that. That's not really in our hands. So we've really had to be creative with any resources we do have to try and do some of the panel management, chronic disease management work.
I just want to add one other point to Pratesh's question because I think it's a really good question. A lot of our focus in safety net primary care transformation has been on transforming the role of the medical assistant. And if you really spend a clinic day following around a medical assistant, I mean, they have so much work, and it's really, you know, all this, like, again, immeasurable work where they're like dealing with the personalities of the folks who come into the clinic. And one inspirational experience for me was visiting South Central Foundation in Anchorage, Alaska, which is, in my opinion, the best primary care in the world. And their medical assistant serves really as the field general. So during the clinic session, they're the ones who are organizing the flow of the clinic and kind of directing the provider to where they need to be. And their medical assistants don't do a lot of panel management outside of what we'll call in-reach. So they don't do outreach, in other words. And so I think evaluating the role of the medical assistant in each of your individual clinics and saying, do we want this person to really focus on optimizing the flow of any given clinic session, or taking them away from the clinic session and letting them focus on outreach? That's a decision that every individual clinic, I think, has to make. If they have the luxury of having a nurse who's able to do some of that panel management, or a clerk that's able to do panel management, that might be a better situation for any individual clinic.
Excellent conversation. Keep the great questions coming, guys. So let's go to Mary Coleman now. Mary had a question about managing transitions of care between inpatient, outpatient environment. Mary, would you mind joining us and introducing yourself?
Hi, I'm Mary Coleman. I'm at LSU, also in New Orleans. I'm questioning about what you do with the patients if they're in the hospital. Do you have teams in the hospital that correlate with your teams in the outpatient clinic?
Oh, yeah, there's so much talk going on here. I think transitions of care is it's not the new thing, but increasingly people are realizing what a critical time that is for patients. One of the things is you actually thought all the way back to our areas of sort of deficiency or improvement opportunities when we did our medical home self-evaluation. One of them was care coordination, care management. So we haven't mentioned it on this webinar yet, but we actually at the same time launched a care management program and do have now our most vulnerable, challenging patients and oftentimes our most high utilizing patients in this care management program now, are starting to be in this care management program. One of the big areas they do focus on is transitions of care. So we're looking at how many times they're in the hospital. When they come out of the hospital, there's a multidisciplinary team that really reaches out to them around those vulnerable times. The challenge for us is that really that's something that we should be doing for all patients when they come out of the hospital. And we've had a lot of interesting work coming from the inpatient service here at the hospital focused on improving transitions of care to the outpatient side, but I actually think that the focus is really shifting towards a really strong inpatient-outpatient partnership in which the primary care home plays a really pivotal role, because people are really realizing that when it emanates from the hospital, it actually doesn't work quite as well. And so now there's a big task force here focused on transitions of care, and our real goal would be to be able to get right in there and connect with the patient immediately when they're coming out of the hospital, or even when to follow up on an ED visit. So I think that is absolutely the next frontier, and we're just kind of taking baby steps in that direction. I don't know if that answered your question, though.
Great. Let's go to Janine Knudsen. Janine had a question about explaining the medical home to patients. Janine, please join us.
Hi, so I'm Janine, and I guess I was already introduced earlier, and I was really curious to know how you explain all this to patients. I haven't been a resident yet, but I can assume that they're already very confused about all the people running around in the clinic, and so I'm curious to know how you help them. You already mentioned handouts and giving them faces and names so they really understand it, but any other tips on how to clarify to them your new model?
Great, thank you for that question. We actually, when we started this process and before we even launched our teams, one of our second-year residents was really interested in this question of what are patients' understandings of their medical home and how best to communicate team-based care in the setting. And so she loved a project where she did a waiting room survey with one of our volunteers on a number of days, and this was as we were developing our patient brochure. And what we found, the results from that survey, were that patients were most interested in getting across the messages that your clinic will be the primary place that coordinates your care across settings, and that you can get care here when you need it, and how best to contact the members of your team. And that's really the wording that we've really tried to uniformly get across to our patients. I remember there was a number of questions initially when we had our medical home wording on the brochure where patients were saying, is this a physical home that I'm going to be moving into? And so, definitely a significant amount of confusion about the concept, and it's confusing to providers, it's confusing to staff as well. And so breaking it down into the basics, which is that your primary care medical home will coordinate your care for your care needs, and that you can contact your primary care clinic for care at the time you need it, when you need it, is the message that we really try to stick through. And in addition to handing out the team brochures so patients know what team they're on, we've been moving more and more towards having things color-coded in the clinic, and that was really why we chose colors as team names, so that across languages it could clearly be communicated what team patients are on, and so paperwork that they receive is in the color of the team that they're on. We have semi-co-located team rooms that are organized by the color of the team, which is where the nursing staff and medical assistant staff for that team work from. So those are some of the attempts to
we put stickers on everybody's cards, according to the color. But I do think it also comes back to, we're also, kind of back to the medical assistant question, we're piloting something where our providers can email their medical assistants and ask them to do a call, a reminder call, or an outreach call to a patient. And so we're kind of getting our feet in the water with more of our team members actually doing those calls to patients and having those primary communications, because then that just builds the relationship. I think it really does all come down to relationships, and it's one thing to kind of say, oh, this is this concept of a medical home, and here's what it's going to mean for you. It's a totally different thing if Dave always gets to work with Jamie, and he can say to his patient, oh, you could call me, or you could call Jamie, or stop by and give this to Jamie when you're next in clinic, or something like that. So the more we can grow all those relationships, the more it's going to be understandable for patients.
So this is actually a question that I have. This is Andrew Morris Singer, so general internist here in Boston. We hear a lot about the transformation process itself at institutions that are undergoing the medical home transformation. We hear about transformation teams, and I was hoping maybe Dave or another member of your team could talk about involving residents in the transformation process, what was the particular framework that you used for doing the transformation? To what degree are the residents involved themselves? And how do you train faculty on this? Most faculty have not been trained in PDSA cycles, microsystem improvement, what have you. Most faculty have not practiced in models of care like this. So how do you sort of navigate that transformation process and engaging faculty and residents in it?
Yeah, thanks, Andrew. So I can take the first stab at sort of with coming into residency. This was a special interest of mine to be involved and help think about this. Though I have to say, after a year and a half of being in residency, it was so important to me to learn how to be a good doctor and learn clinical medicine that I've kind of, and the other point, I guess, is that it's hard to be objective when you yourself are in the clinic and learning and trying to improve your own clinical skills rather than just your experience. So I've kind of stayed out of it as a resident, though I will come to the Yellow Team meetings and get excited with the staff about stuff that's happened. So I think that's been my personal experience, and I think Rena or Claire can speak to engaging faculty and other residents as well.
I think one thing that you hear a lot of in talking to people who are doing transformation in their own clinics is that there's a lot of dialogue about resistance from the providers. And interestingly, in our process, that was the least powerful resistance that we found amongst various staff and providers groups. The providers were actually the most welcoming, even though they hadn't had experience practicing in team-based models. But I think that largely relates to the structure of academic clinics. When providers are only there 1/2 day of the full week, they feel all the more pressure around building continuity and making sure things don't fall through the cracks for their patients on the other days of the week. And it's all the more important to have a supportive team structure in place for that. So I think we haven't faced as much of that and actually have had a lot of welcomeness from the residents, from the attendings in terms of these changes coming. In terms of your question about engagement in the process of the actual transformation, we've definitely seen a progression that as people see the changes affecting their experience in clinic in a positive way, it fosters excitement and then a desire to participate more actively. So one of our long-term faculty who's been practicing in this clinic for over 10 to 15 years, the first time that she participated in our new team model, she said it was the first time in over 10 years that she was able to see all of her patients on her schedule and write all of her notes and be done by the end of the clinic session. Previously at meetings, she's had reluctance about the team model and voiced some concerns, and after this, it really changed her level of engagement, and that's true, I think, for a number of other people in terms of the process. I think one of the challenges is that because the providers are often only here 1 day or 1/2 day a week, being really actively involved in the having their really in the weeds in terms of the specifics of the changes is challenging. And one other way that we've fostered this specifically for the residents is our quality improvement curriculum that Claire has really developed over the last number of years, for which every resident who has continuity clinic at GMC has a specific QI project in their 2nd and 3rd years, and so they choose, based on their interest, what project or QI project they want to be involved in. But a number of the residents have chosen to have projects, as I was mentioning in the last question about the resident who is interested in working on the patient's understanding of the medical home. There have been a range of projects from how do we improve our communication with our team MEAs by email and outside of the clinic visit. Another resident working specifically with the care management program. So doing their QI projects with the changes that the clinic has prioritized, I think, has been a key. I'll hand it over to Claire.
Yeah, I think that's true, but I also think it's I think that we kind of we try to have realistic expectations about what residents are able to do, and so we kind of plan. A few years ago, we actually had a consultant come on board who did a staff retreat for us, and he essentially said, so many of your providers are part-time that your the culture of your staff has to be ironclad. Like you have to make your staff the heart and soul of the clinic, and that certainly doesn't mean that residents aren't a totally integral part, but I think we do have to have really realistic expectations, and I know it can actually be stressful for residents who really want to take on the residents who care the most sometimes can get the most stressed out about a QI project because they really care about transforming things and changing things, and yet they just get their feet in and they have to disappear onto the wards, and it's just, you have to juggle so many things. So I think what we have really felt is we need to kind of blaze forward with this work, and any chance we have for resident input, we're going to take it. So we'll plan our team meetings kind of with the staff schedules in mind, and then really make sure to get the word out to our residents, and however many residents can come, that's fantastic, and we're going to pick their brains as much as we can. But just being realistic about how much they actually can guide the process.
So I think.
Well, I'm going to.
Yeah. So sorry. Please. Yeah.
No, please, Dave. Go ahead.
No. Did you have another question? I didn't want to. I didn't know if this was concluding final thoughts or.
Well, Dave, I was actually going to ask that question I always ask at the end of taking a history, which is basically, I've asked a lot of questions, but is there anything that you haven't been asked tonight that you really think folks here should know?
So I can take the first stab. So I think the lesson that clearly, if you were on at the beginning of the call, you can see that I learned is that transforming to team-based care and to sort of our ideal of the patient-centered medical home in an academic medical center, not only is it possible, but it really is so crucial to moving forward with the things that we're trying to do with primary care in this country. So I am so happy to admit that I was so incredibly wrong about whether or not this transformation was worth it or possible, and I've been blown away in such an incredible way that it's so different from what I expected coming in. It was that everybody has been so involved in making this possible, and there's been such a cultural transformation and feeling of optimism within this tiny clinic and kind of the first ground floor with no windows, with 83 part-time providers and 6,000 something patients. So it's been an incredible experience, and I hope that that Rena and Claire are able to continue to talk about the virtues of this transformation and write about it, and hopefully you'll be seeing them at conferences talking about it, because I think that this is the way we need to go as an institution for all of our academic medical centers.
I would say that being a part of this process has really been, it has been something that's made me excited about coming to work in our clinic every day, to see that beyond our leadership team who's invested in this, how much has been taken up by our staff and by our providers to keep forging this process ahead and making a lot of exciting changes that are palpably affecting the experience that our staff and providers have in clinic, as well as our patients. There's still a lot of work to be done, and I definitely, through Primary Care Progress, you're welcome to get all of our contact emails on this call, and feel free to contact us with any further questions that we were unable to answer today. We would love to hear about the work that's going on in your clinics and practices, as we all continue to struggle with how we make the redesign work happen in academic clinics.
Yeah, and I guess I would just also add that we'd love to hear. It sounds like so many people on this call also have clinics that are going through the same change. It would be great to keep sharing information and just sharing different concrete steps that we're all trying to take to make this reality. I think actually the most fantastic thing about the transformation, in my experience, is that we've talked to a lot of other clinics who one of the first things they had to do when they started changing the way they offered care was to have a big conversation and get aligned around the mission of what they were all trying to do. And just in reflecting back on our experience, we've never had to do that, because we actually are so lucky to have the staff and the residents and the faculty that we have. Everybody really has chosen to work in this very specific, crazy as it is, and no windows, and and all of the different struggles that we see our patients going through. People have really chosen to work here, and so once people really got past the hump of thinking that you can't do this kind of transformation in a safety net clinic and in a resident clinic, that's when we really kind of got into the trenches and started working on things, and it was a really wonderful moment when we realized we were sort of crossing that hump and coming down just into the nitty-gritty of planning how it was going to work, not whether we should do it.
Well, Rena, Claire, and Dave, I want to first of all thank you for all of those great points and this incredibly informative presentation, and for everyone on this call for the rich conversation and questions that you gave to all of us. I'm Melissa Galuli, and I'm the Executive Director here at Primary Care Progress. And as Andrew mentioned in the beginning of the call, we've heard from all of you that these presentations are not only instructive, but a wonderful way for you to connect with like-minded colleagues across the country. And so we've heard you loud and clear, and we're going to make these types of presentations a bigger part of our programs at PCP. And that's why we're so thrilled to have Janine joining us as our first Clinical Innovation Fellow. She'll be working with PCP to further build out this network. And one of her many responsibilities will be helping us to capture some of the instructive content that comes out of conversations like this, but then also to bring the conversation offline. So for this call, we'll be starting up a forum on the PCP website related to the webinar. So please visit the website to ask additional questions or to share some of your own stories and experiences related to tonight's conversation and your involvement in practice transformation. And thank you, Rena, Claire, and Dave, for being so generous to offer to follow up with folks who have additional questions. Janine will also be responsible for arranging future webinars, so please be on the lookout for the next one. It will be occurring in January, and we'll start regularly posting others that are scheduled throughout 2013. So I want to thank you all for joining us tonight. And for those, we want to wish you all a great holiday. And it sounds like Dave might have a closing, final parting thought for you. So go ahead, Dave.
Oh, thank you. Okay, so we just also want the opportunity to thank Primary Care Progress and Andrew and Melissa and Alyssa for setting this all up, because this is a great opportunity, and it sounds like it'll be recorded, so we're going to be famous. Thank you. And we just love that Primary Care Progress exists, and I can't imagine why anyone doesn't want to go into primary care, but I'm glad that this organization exists to really help people realize that.
Thank you, guys. Now that we've all shown our appreciation for each other and everyone on the line, thank you, everyone, again. We hope that everyone has a wonderful holiday, and we hope that we will be in touch with everyone before the end of the year. But for those of you who we don't talk to directly, please, please, please be on the lookout for all of our upcoming Clinical Innovation Network opportunities starting out in the new year. Thank you.